Hi, my name's Lori Bechard, and I'm a registered dietitian and professor, and I specialize in clinical nutrition research in pediatrics. This course is just one in a series of modules on indirect calorimetry brought to you by Channel 1, On-Demand Nutrition Education. This module is part 2 in a 4-part series. We are focusing on pediatrics. Today, we're looking at normal measurement parameters and test validity. Our objectives for this session are to get comfortable with recognizing and validating indirect calorimetry data and to understand factors that influence the data produced by the indirect calorimetry device. Indirect calorimeters, or metabolic carts, measure oxygen consumption and carbon dioxide production as an indirect determination of energy expended by the body. Basal metabolic rate, or BMR, is the energy required for normal bodily functions while minimizing extraneous variables, and measured resting energy expenditure, or REE, is the clinical surrogate of BMR. The indirect calorimeter measures inspired oxygen and carbon dioxide output through a mixing chamber of gas exchange. The output measures are VCO2 and VO2 in milliliters per minute. These variables are used in the modified Weir equation to calculate REE, as shown here. When estimating energy requirements for an individual, the major components of energy expenditure should be considered. The majority of energy expended is for resting energy expenditure and is determined largely by age, sex, overall body size and composition, and genetic variants. The thermic effect of food is the energy required for digesting and absorbing nutrients from oral or enteral diets. And physical activity energy expenditure is driven by individual and external factors related to body movement. The data obtained from indirect calorimetry provides a measurement of resting energy expenditure with influences by the components involved in that process, depending on the individual and conditions of the testing environment. REE comprises about 60% of TEE, or total energy expenditure, and is derived mostly from muscle mass. Activity will vary widely among children, but may be minimal during acute illness. The energy cost of growth is the calories needed to synthesize new tissue and is a significant proportion of TEE only in about the first 3 years of life. In the first month of life, it is a very high proportion, up to 60% of TEE, and subsequently it declines over time with an average of about 33% of energy needs in infants 0 to 4 months of age. After 3 years of age, it falls to about 1 to 2% until a slight increase around puberty. The thermic effect of food is about 10% of TEE, and another 5% is attributed to obligatory losses through urine and stool, though this can vary dramatically under conditions of illness or pathologies related to digestion and elimination. One of the problems with developing an accurate predictive equation for critically ill children is the heterogeneity in age, weight, muscle mass, and severity of illness in the PICU. Most studies come to the same conclusion. Current predictive equations do not accurately predict REE in critically ill children. Factors that may influence energy expenditure during acute or critical illness may substantially affect REE measurements. REE is higher with fever or certain medications and lower with other medications and factors. These clinical factors may lead to unpredictable and widely variable REEs over the course of a hospitalization. The RQ is the ratio of carbon dioxide produced, or VCO2, to oxygen consumed, or VO2, and it reflects the predominant substrate being metabolized. An RQ of 0.7 suggests fat oxidation consistent with starvation or fasting. An RQ of 0.85 suggests a mixed substrate use, and an RQ of 1.0 suggests carbohydrate oxidation. RQs greater than 1 may indicate lipogenesis or overfeeding. Values outside 0.6 to 1.3 are often considered physiologically implausible, or may reflect technical errors or non-steady state conditions. RQ alone should not be used to determine the metabolic state of an individual, but can be one data point to confirm suspected nutrient utilization in the context of measured resting energy expenditure. In order to assume validity of an IC test, check the ranges of RQ, coefficient of variability, time in steady state, and calibration status. RQ values outside the valid range may indicate measurement error or non-steady state conditions, which are more common in pediatric ICU settings due to movement, crying, or ventilator changes. Coefficients of variability should be less than 5% for VO2, VCO2, and RQ. And steady state is defined by a time period of at least 5 minutes with less than 10% variation in VO2 and VCO2, ideally longer time periods to suggest stability. These are some factors that may impede valid IC results. Inspired air is calculated using the Haldane transformation, and as FiO2 increases, large errors are introduced into the calculation of VO2. So IC will be inaccurate when FiO2 is set to 60% or higher in ventilated patients. Consider air leaks of any kind in the body or ventilation tubing and clinical instability, which will likely impede the ability to achieve steady state, invalidating the IC results. Other important factors to consider in the use of indirect calorimetry, specifically in children, relate to the unique circumstances of the patient and their environment. Testing will be difficult and maybe impossible with young children who are awake, especially toddler-aged kids, since they may be unable to understand and be still for the time required. Since feeding impacts energy expenditure, the best results will likely be obtained in a fasting state, although in some situations, patients receiving continuous feeding may be appropriate. And with canopy studies, all sources of supplemental oxygen or air must be removed. So if a patient cannot tolerate that, they would not be appropriate for IC. I would encourage you to watch other videos in the Indirect Calorimetry Channel 1 series to learn more from my esteemed colleagues on this topic. Have a great day. Thank you.